Can you hear me?
Yeah.
Excellent. Thank you very much, Dr. Anasika, and thank you to everyone who is sharing of their Saturday morning, afternoon, or evening with us. Yes, so today we'll be discussing. So I think, at the start of the webinar series, we sort of spent the first session discussing MRI physics, the basics of cardiac magnetic resonance imaging, why we do it in cardiac disease. And then our second session was basically quite technical to arm us with the information we need to see how we can actually pivot on our existing infrastructure to upgrade to cardiac MRI capabilities. And hence, from this session forwards, we will then be discussing the unique role of cardiac MRI in different cardiovascular disease entities, pathologies. We'll be highlighting the strengths, why we use it, and sort of going into a bit more detail. So the reason we're starting off with coronary artery disease is because this is really what keeps us all up at night. This is the biggest contributor to the cardiovascular disease burden, and cardiovascular disease burden is the biggest contributor to human morbidity and mortality. When we look at these graphs from the Global Burden of Disease Repository, we can see that Apologies. We can see that, in the past, say, 3 to 4 decades, unfortunately, ischemic heart disease still maintains an ignoble top row and an ignoble position at the top of the leaderboard for what the reason why humans die, unfortunately. And we can see that this has remained the case despite advances in technology, advances in earlier detection, preventive cardiology, preventive medicine generally. It doesn't mean that we are failing. It just demonstrates that we are not yet distinctly winning. We're not yet distinctly ahead of the curve of this pathology. And that's really 40% of our cardiovascular diseases are contributed by coronary artery disease. Bringing it closer home, when we look at this excellent data presented from Nigeria about Nigerian patients, the trend graph on the left is from Professor Sezuo's team from the race registry, where we can see that the utility of coronary angiography in managing patients with cardiovascular disease is increasing, and this does not necessarily reflect increasing incidence or prevalence strictly, but also just increase the availability of these tools and expertise. PCI availability is also increasing over time, as is coronary artery bypass grafts, and therefore revascularization is getting more mainstay in our climes. The graphical abstract on the right is from Professor Ga's team, where they basically presented evidence from longitudinal data on, the state and the burden of cardiovascular diseases in Nigeria. We can see that the most common risk factors is hypertension, 30.6%, which directly aligns with another study from Professor Sezuo's team that has demonstrated that 1 in 3 Nigerians are hypertensive. But these are sort of what, are generally called the traditional risk factors. And therefore, if we're not seeing as much coronary artery disease in Nigeria as in other parts of the world, it may not necessarily mean that we are experiencing them less. It may just mean that we're picking them up less. And I think that's sort of where cardiovascular magnetic resonance imaging has a mainstay in improving that, as well as giving us another tool to help our patients with. So, coronary artery disease essentially progresses from completely clean, pristine arteries, as shown on image 1, to occlusion. And the reason why patients or arteries will progress from 1 to 6 is a combination of age, genetics, non-modifiable factors like age and gender, and modifiable risk factors like traditional risk factors, hypertension, dyslipidemia, diabetes, other causes of vascular inflammation, prominently smoking. And evidently, these pipes exist just to primarily to supply muscle to to supply blood to the myocardial bed. We can see that usually the buildup of plaque is progressive, And longitudinal data from different parts of the world and this have demonstrated that patients who have coronary artery stenosis with stenosis less than 50% of the lumen are unlikely to have flow limitation, and the myocardium is unlikely to have paucity of blood flow or ischemia in any circumstances, including stress. However, above 50%, the chances of myocardial ischemia increases as the stenosis progresses, such that above 70%, we're almost certain that myocardial beds supplied by coronary arteries with more than 70% stenosis will have ischemia. And ischemia is not benign, it's the biggest driver for the adverse cardiovascular events. So the patient could present to our clinic with angina, which is generally traditionally described as exertional chest pain or tightness. And of course, there's an angina equivalent in patients who experience their pain differently, like diabetics, where it could be dyspnea or other symptoms. Now, if we have a complete occlusion, either suddenly or due to plaque rupture, and we have a clot fill up this lumen, then that's in principle how the myocardial infarction occurs. And whilst that is immediately life-threatening, as on the previous graph, we can see that we have increased revascularization capacities in our country, and such that we expect that a lot of our patients with acute myocardial infarction, STEMI or non-STEMI, would survive. Unfortunately, this does not get them out of the woods because one, they then have devitalized myocardium, they could progress to heart failure, they could experience dangerous arrhythmias, or indeed die from heart failure or acute or chronic sequelae of myocardial infarction. These are sort of graphs from on the right. We have an infographic from the American Heart Association ACC chest pain guidelines, and on the left is the equivalent guideline from the ESC. On the right, we're basically, on the left rather, the one that says chest pains, we're basically dealing with patients who present with acute chest pain, sudden onset of chest pain at exertion or at rest. It's important that we draw high sensitivity troponins, that they are rapidly transferred to a place of safety where they can get the care they need, including acute revascularization if required, that we communicate with our patients. It's also important that we stratify who needs this high level care and who doesn't. And therefore, there are traditional demonstrations or characteristics of chest pain that represent myocardial ischemia versus that doesn't, that may represent pneumonia or pleurisy. On the left, the ESC presents essentially the spectrum of possible presentations of patients with chronic coronary artery disease and the underlying pathology that fosters this. This becomes increasingly relevant when we see what actually we pick up on cardiovascular MR imaging. I started off with this slide just to say that as robust as I want to present CMR in coronary artery disease to be, which it is, we have sort of a tiered approach to screening and investigating patients with chest pain. This is from the same AHA chest pain guidelines, and the constellation of conclusion of whether this is high-risk chest pain, whether this is an ACS, or whether this is non-cardiac chest pain or atypical chest pain, depends on the combination of the patient's presentation, bedside tests like EKG and transthoracic echocardiogram if available. But a lot depends on the patient's history. If a patient's presenting with features very suggestive of an acute coronary syndrome, they need to be urgently revascularized. They may benefit from cardiac MR imaging at some point in their journey, but they need to be revascularized. This flowchart also demonstrates it. Essentially, we obtain troponin and we think they are high risk for an ACS. They need to have an invasive coronary angiogram. But then there are patients that present with more stable chest pain where the story is typical angina, exertional chest pain, central crushing, sometimes radiating to the jaw or the left arm, and we're quite suspicious that this is angina. Now, these are flowcharts, again, from the AHA guidance. Essentially, it's all about risk stratification. What is the pretest probability that this patient has coronary artery disease? And therefore, we're trying to put together what the patient has told us and their constitutional and biological makeup to think where they are in the risk category. Are they low risk for CAD? If a 22-year-old has viral symptoms and central chest pain that is worse on respiration, well, they probably have myopericarditis, even if they have a troponin positive chest pain rather than a STEMI. But we still go through the workflow just to be sure we're meticulous. And therefore, if patients have no history of coronary artery disease and are low risk pre-test probability for having CAD, then, they can have outpatient tests. We probably need to test their anatomy, screen their anatomy. Calcium score is powerful because even if they have a stress test that demonstrates that they do not have ischemia that is inducible on stress, a calcium score is powerful and has a +2A recommendation here because it tells us how much calcified atherosclerosis they have in their coronary bed, which has been proven in lots of longitudinal data to have a linear relationship with their risks of MACE. The converse is true that if someone presents and we think they are low risk pretest probability and they have a calcium score of 0, we're very reassured that they certainly do not have coronary artery disease and we should not look any further. But the gray area comes when patients are intermediate to high risk. Probably they are middle-aged, they're diabetic or hypertensive, or they have previously smoked, and we think, yes, they have an intermediate pretest probability. Stress cardiac MRI imaging has a class 1 recommendation, and therefore we should recommend this once available because it gives us a lot of information which we will go through in due course. Again, if patients have known coronary artery disease, and we know that this disease is potentially obstructive, i.e. more than 50% stenosis, then we should also offer them stress testing, and that has a class 1 indication as well. Now, this, I'll show you this. So when we looked at that image playing, we could see that this left ventricle is dilated, it's severely impaired, the septum barely moves. This apical 4-chamber transthoracic echocardiogram, will be worrying to anybody who, any cardiologist or anyone who reviews echoes. But the question is, what could this be? What exactly is the underlying etiology? The reason the underlying etiology is so important to be deciphered is that what we then offer the patient is very different. The patient's outlook is different. The patient's prognosis is different. And what we do for them or the other members of their family is very different. Could this be a massive proximal LAD? In fact, it's possible. Could this be post-myocarditis? Viral myocarditis. It's possible if a patient has a cancer diagnosis and has been given tyrosine kinase inhibitors. Could this be, myocarditis resulting from that? It is possible. It's documented. And therefore, we don't know. We can't really offer this patient the best care available in medicine in the 21st century if we have only this echocardiogram to work with. And I say this as someone who loves echoes, who keeps reviewing echoes, but we recognize that echocardiography remains indispensable because it's the only imaging tool that is available at the patient's bedside, but also it has its limitations. So we can't really comment on the etiology. We can only describe what this LV looks like. Cardiac MRI strength in the management of coronary artery disease is essentially the full spectrum of the disease process. Whilst it's not your erudite tool in demonstrating coronary arteries because they are small and they're very mobile, and we had previously mentioned the spatial and temporal resolution, it is possible to measure coronary artery flow with cardiac MRI, but it's not its main strength. To demonstrate arteries anatomically, we need CT coronary angiogram or invasive angiography with CT equivalent to invasive with current contemporary scanners. However, these possibilities listed on the screen are exactly what cardiac MRI can do in the journey of managing patients with CAD. The gold stars are actually for the domains and the functions where cardiac MRI is gold standard, where it's unbeatable and where it's still your best tool. And therefore, we can see that, the reason why we would really want to accurately determine LV function is that we make sure that we are treating the patient at the right cutoff with the medications and the strategies that lead to the positive outcomes and reduction of MACE that we aim for. It's important to know when patients are ischemic because ischemia precedes badness and MACE. And we also can revascularize them and get them out of ischemia. Same also for scar quantification. Fibrosis has been proven in every version, every possible disease phenotype of cardiology to be associated with increased major adverse cardiovascular events. We can also diagnose a myocardial infarction, especially when the story is not very clear from at the bedside, and also its acute and chronic complications such as microvascular obstruction, the presence of LV thrombus, etc. So we'll try to get into most of these today. And the next set of slides will just present, sort of make the case for cardiac MRI. Why MRI? Why not other tools? Why not echo? Why not SPECT? So this is a study that sort of compared patients post-acute STEMI. This was a Swedish study done at Karolinska. A crop of patients post-acute STEMI who have undergone 3D echo, SPECT, cardiac MRI. We can see that the intra-class correlation coefficient of agreement between all three modalities basically presents CMR to be most powerful. It had the best rendition of LV volumes. Echo underestimated endosolic volume by a median of about 64 mils and SPECT by 55. So SPECT actually performed better than 3D echo. And we sort of know this in the nuclear cardiology world, that the volumes are underestimated, but in a proportional way such that ejection fraction is maintained. But cardiac MRI, sort of remains gold standard. And this and other studies like HIT have reiterated this. Now, the specific roles in coronary artery disease. So when we look at the FAME trials, there's now been FAME 1, 2, 3 trials. And essentially the constellation of them demonstrates that they established that, one, a stress cardiac MRI-based strategy, a physiology-based strategy is pivotal to making the best decisions in patients with coronary artery disease. So the FAME 1 trials looked at patients with multivessel CAD, intravascular angiography-derived FFR, fractional flow reserve versus angiography assessment of stenosis versus FFR-guided assessment of stenosis as the guide for PCI. And therefore, this was patients with multivessel disease in the cath lab. Do we think it's stenosed versus do we put a pressure wire through and decide if it's stenosed? And we know that FFR guidance essentially amplifies the power of your decision-making and reduces MACE, as this Kaplan-Meier curves demonstrate. Now, the next set of trials that have sort of also made a case for stress CMR in IHD is the CMAC trial. So CMAC, there's now been CMAC 1 and 2, and they sort of both looked at the same question from different perspectives, and both basically put together demonstrate that a stress CMR guided strategy of managing patients with coronary artery disease increased detection of ischemia equivalent to cath lab FFR guidance. It reduced unnecessary invasive procedures because given that it's equivalent, you no longer need to take people to the lab to test, check if they are stenosed and put a pressure wire down. You can do a stress CMR and end up at the same destination. And patients on the stress CMR arm for both CMAC trials had reduced sequential tests. And therefore, from a health system perspective, especially in a health system where patients are paying out of pocket, it actually is cheaper to have an MRI, stress MRI first, rather than go through the sequences and have multiple tests in the long run. The MR-informed trial basically is compared in patients with multi-vessel but stable coronary artery disease. It compared a stress CMR guided strategy to an angiographically derived FFR guided strategy. And this was a non-inferiority sort of clinical effectiveness trial. And the stress CMR arm was demonstrated to be non-inferior to the angiographically derived FFR group. So we can see the Kaplan-Meier curves on the right, and we see that basically these curves overlay each other. P-value is 0.91. There's absolutely no significance. And therefore, taking a patient to the cath lab to check their stenosis and put a pressure wire down to test if there's flow limitation is exactly equivalent to putting them through a stress CMR to get the same information. Now, the main workhorse for MRI is actually fibrosis imaging, like I previously alluded to. And this is a sort of legacy study from, I believe, 2006, where a kind patient who had burnt out hypertrophic cardiomyopathy kindly donated her heart after her, obviously, at the time saying that after her death, she was happy for it to be scrutinized. And this was in the early days of cardiac MRI. So this was ante-mortem cardiac MRI and post-mortem autopsy. And we can see that on the cardiac MRI image, you can see the myocardium dark in the septum. We can see that the anterior wall is quite white and the lateral wall still has a stripe of black. If we think black is myocardium and white is probably scar. Now, when we look at this post-mortem sample, we can see that one was histologically identified to have replacement fibrosis, minimal myocardial and cardiomyocytes, all collagen bundles. And that corresponds with this anterior wall here. Two had fibrofatty replacement, and this is just inferior to the RV insertion point. And we can also see that it's sort of lit up. And then three, which seemed dark and, if we just took the late gadolinium pictures, we'll think this may be preserved myocardium, depending on what it does on cine. Actually had fibrofatty replacement, and obviously actually had interstitial fibrosis rather. And whilst late GAD does not necessarily tell us if there's interstitial fibrosis, because it basically demonstrates replacement fibrosis and completely expanded extracellular space, we could have deduced that this was abnormal with sort of T1 mapping, because that will pick up interstitial fibrosis. Scar quantification has been proven to be a strong, robust tool in the management of all phenotypes of cardiovascular diseases. And in fairness, in every disease process that this has been looked at, genetic cardiomyopathies, ischemic heart disease, arrhythmias, the Kaplan-Meier curves always look like this. Patients who have scar do very poorly, unfortunately. Now, in the specific management of patients with coronary artery disease, Dr. Pereira's team at King's College London presented this seminal paper on the topic about 2-3 years ago. And basically, they looked at patients with known ischemic heart disease, coronary artery disease, including left main stem stenosis, with ejection fraction less than 35%. And therefore, this is the highest risk profile, really, for patients with coronary artery disease. And they randomized them to an optimal medical therapy only arm versus a PCI plus optimal medical therapy group. Now, surprise, surprise, these patients did exactly the same. There were patients on optimal medical therapy who had tight left main stem stenosis. There were similar patients in the PCI group, an exactly balanced and randomized group on each arm, and they did exactly the same. It tells us that in this patient group, revascularizing them alone does not make a difference. Subsequent post hoc analysis from this group, from the same patient, from the same study, basically shows that, when we are now looking at the primary outcomes and the secondary outcomes, and what actually in the data we gather tells us more. Because at the end of the day, the first question the patient asks is, "Doctor, what's wrong with me?" The second question and subsequent questions through the life course management is really about risk stratification. How do I prevent patients with cardiovascular diseases from dying? If we go back to that global burden of disease data, how do we take IHD off that top tier where it's the commonest reason why people die, why adults die in the world? So, looking through sort of the hard data from this study and impact on primary outcome, all-cause death, cardiovascular death, heart failure hospitalization, and improved LV function, we can see that these plots are basically straddling one. So estimation of the quantity of viable myocardium, which is another way to present sort of ejection fraction in a different way, does not actually, relying on it to prognosticate our patients or stratify our patients does not really phenotype them. They all it doesn't diversify the group, it doesn't stratify the group. They're all still within a cluster. Estimating the amount of non-viable myocardium does not necessarily tell us a lot about how they will do in the future. Apart from that, maybe their LV function will not improve a lot if they have a lot of non-viable myocardium. But then look at SCA. Nearly through the outcomes reviewed, we had significant signal of how we can rely on SCA to prognosticate patients. If patients have more SCA, they are more likely to have a primary outcome, which was all-cause mortality plus heart failure hospitalization. If they have more SCA, they are more likely to die. If they have more SCA, they are even more likely to die of cardiovascular causes. They are more likely to come into hospital with a heart failure hospitalization, and they are less likely for their LV to improve. And the only way we can quantify SCAs is by leg gadolinium enhancement assessment with cardiac MRI imaging. So if we get back to this, infographic, essentially through the spectrum of coronary artery disease, initially we start with an anatomical assessment. If patients need to be assessed, if they're entirely low risk, we do nothing. We reassure them they probably have an alternate diagnosis. If they have a bit of risk, we can do a calcium score, like we said, to prognosticate. It shows us early plaque, it quantifies it, it gives us outcome data. If we think they have a bit more plaque and the disease progresses, this is best assessed by coronary angiography, which is CT is equivalent to invasive angiogram in this regard, but obviously is non-invasive and preferred. Now, the moment we start, the degree of narrowing and plaque accumulation starts leading to up to 50% or close to 50% stenosis. We really want to do an anatomical, more relevantly, a functional assessment, because whether they have plaque or not now does not tell us how they will do. It's actually whether they have ischemia, whether they have SCA. And that's where we then start relying on stress cardiac MRI viability or stress MRI and a lot more. And, if a vessel is blocked, we need to look at it directly in an angio in the cath lab. So cardiac MRI, essentially, the equipment, we've gone through this in previous sessions. We need a magnet. It's a powerful magnet. We need to abide by safety measures to make sure that the patient and personnel are safe. We also need to have emergency equipment to respond to patients' decompensation with, and we have to have the software so that we can do specific sequences to look for specific things as we scan these patients. So the next set of slides, we're just going to talk through, sort of protocoling. So essentially, when we are assessing a patient with coronary artery disease, what are the questions we are asking? We want to know what their LV function is. We want to know if their left ventricle is entirely viable. What is viability? Viability is really the amount of the myocardium that is still participating in cardiac, contraction, and therefore this is healthy myocardium supplied by blood, not scarred. So we want to assess myocardial viability. We also want to assess the scar burden because, as we have seen from previous slides, this gives us a lot of information. And then, if we add on the stress component, stress perfusion, we want to see if we can induce ischemia in the right circumstances by manipulating their physiology a bit. So I'm just going to quickly go through this. So essentially, first set of images we acquire are our localizers. We basically acquire transaxial localizer and stack, and then derive our sagittal localizers and coronal localizers from that. This could be achieved free breathing or with 1 or 2 breath holds. But, this is the body of data with which we then get all our other planes subsequently. The next set is then to get our cine stack, which is a short axis stack, as well as our long axis. So from that transaxial, we acquire the localizers. We basically want to put an orthogonal plane that is parallel to the septum, and an orthogonal plane that is parallel to the septum that goes through the mitral valve and the apex to derive sort of our pseudo 2-chamber. And then from the 2-chamber, we derive our pseudo 4-chamber. And then we also get a short axis stack. Then we do the cines. Cines basically are the equivalent. It just means the dynamic moving images that play like a video. Then it's fair to note that these are pseudo views. They are not your true 2-chamber and 4-chamber. So it's like your VLA, vertical long axis, and horizontal long axis. In an ideal world, and that's really what we do, we want to derive true 2 and 4 chamber views. So from that short axis stack we have acquired here, we then want to put an orthogonal plane that goes through the most lateral part of the RV and then through the LV. And then, coinciding with an orthogonal plane that goes through the pseudo 2 chamber views just below the anterolateral papillary muscle and through its apex. This plane, as we can see, is not necessarily right in the middle of the cavity or going sort of bisecting the mitral valve. We just need it slightly lower than the papillary muscle here. And then we get it through the true 4 chamber. And then 2 other orthogonal planes that go through the anterior and inferior wall of the short axis, as well as a parallel orthogonal plane through the 4 chamber view that goes through the mitral valve and apex, then gives us a true 2 chamber. And it's actually relying, performing these planes exactly as prescribed that gives cardiac MRI that strong reliability and it being gold standard for the assessment of volumes. And then we can do a 3 chamber view by then putting this orthogonal plane through the short axis view and the 2 chamber view, and then we get a true 3 chamber view. And that way we have acquired our dynamics, the motion, which we will do our volumetric assessments with. We also want to, accurately assess the right ventricle. So from the localizers, we basically get an RV stack transaxial, and then we put orthogonal planes. It's fair to say that these images I'm referring to are actually freely available online on the European Society of Cardiology EACVI section. So within the ESC's website, there's an EACVI, and you don't have to be a member of ESC to have access to this. There's an EACVI, which is European Association of Cardiovascular Imaging, and these PDFs are widely available. I will download them and we will share them with the rest of the, with the information you receive after this session so that you have it. But it's within there and it's a good reference to make sure that our planes are reliable. Because, if our planes are not reliable, then the reliability of CMR in assessing volumes falls off the perch. Ejection fraction is no longer accurate. And then the domino effect of this just continues. So we get accurate assessment of our right ventricular volume and function having with this strategy. And then the next thing is the main vessels. For when assessing for coronary artery disease or any cardiac MRI scan, these are basically standard stacks that are acquired. So basically for the for the pulmonary arteries, you basically want to, on that initial transaxial stack, put through orthogonal planes that go through the main pulmonary artery and through a branch, and then you get the sagittal and coronal versions of that branch, and you do it for the right and the left. Now, for the aorta, that's 3 chamber view. So we can see that after our initial sort of localizers, every other image is dependent on what we've already done. So if we get it wrong, we're going to keep getting off-axis views, and therefore our quantification just is no longer as reliable. So, without belaboring a maxim that the NHS loves a lot, but, we just want to get it right the first time. So to get the aorta, we want to put an orthogonal view that goes in the 3 chamber view that goes through the aortic valve that's entirely perpendicular to the valve, and that gives us a coronal LVOT. And then we then put parallel planes through the coronal LVOT to get our through aortic valve planes. And then, if we want to do the hockey stick for the arch, then there's a 3-point planning where we basically put sort of anchors in different parts of the aorta so that the magnet relies on it to then reconstruct an image. And that's how we get our ideal, aorta hockey stick, thoracic aorta hockey stick. And then the flows are similar because essentially, remember, I think at session 1, we touched on it, that we basically want to get in-plane and through-plane views. That way you can visualize blood as it goes through the valve, but you can also do velocity-encoded assessments where we can then assess the peak velocity through the valve. So we basically put an in-plane and through-plane views, and then we can get the flows. And this is immensely helpful, especially in the assessment of patients with congenital heart disease, which we have a session for. I believe that is session 6. So stay tuned. This is one of the many reasons why not to miss any session here. We're just building on each other. I'm going to get a bit fast because I think I'm stumped for time. But essentially, now, stress perfusion, the whole idea of stress of perfusion, cardiac MRI, or perfusion, anything really, is that you want to infuse an agent and sort of visualize it as it goes through your area of interest. So this is very similar to what we do in like PET, where we infuse an agent, a radio tracer that the myocardium holds onto, and then we scan as, the myocardium emits at rest and at stress. So basically it means that we need an agent that perfuses the myocardium. We also need another agent that induces stress so that we can test the perfusion at rest and then test again when we have stress. The reason for this is that, as we know, coronary artery disease is characterized by angina, and angina is defined as exertional chest discomfort, chest tightness, or pain. So if we're going to elicit a corollary for it, then we need to induce exertion. Now, whilst historically it was sort of adrenergic mediated exertion, so exercise, treadmill, or dobutamine, increasing knowledge of how stenosed arteries behave inform us that when epicardial arteries have a stenosis, the response to vasodilatory stress, vasodilatory agents, is different. So whilst healthy arteries will dilate and probably double the flow through them when exposed to vasodilation, areas of stenosis do not, and therefore they sort of amplify the flow reduction. And that's really the basis for our stress tests. So for the perfusion, we want to derive sort of pulse sequences so that we can monitor and, have excellent signal to noise ratio, excellent image contrast. So, and also see how the myocardium gets perfused by this agent. A perfusion agent is basically gadolinium. So that means that we have to infuse gadolinium and we have to give a stress agent. Generally, we give the stress agent and then conventionally is regadenoson these days. So, you give the regadenoson and about 45 to 60 seconds later, you infuse gadolinium, but then you start imaging whilst the myocardium is nulled, i.e. black, so that you then see it go through. And you want to take a couple slices, 2-3 slices every heartbeat, and we generally acquire image at the base of the heart and middle cavity and at the apex. So this basically just is what we're trying to achieve. This demonstrates, so we can see that because these stress cardiac MRI has come after stress nuclear cardiology, where conventionally we stack the stress images on top and the rest images below. We still do that in cardiac MRI. And I think it just, people have trained this way. There's no point changing a strategy that is already encoded in the brain. So this is at rest. And we can see that if just for purpose of analogy, this myocardium was initially black because it was nulled before we started imaging. But then obviously this myocardium has gone from black to a bit of white as the gadolinium goes into it and completely perfuses it. So we can see that there are no defects. There's no area of convincing blackness that is more than 2 pixels. There's a bit of a stripe here, but it's thin, it's probably 1 pixel, and it's not reliable. So at rest, this patient had really good perfusion, every segment. And remember, we're looking at the myocardium sort of in that bullseye plot, 16 or 17 segment model, whichever you sort of use. But it's well perfused. Now, having induced adenosine stress, it was in this case, we can see that whilst the lateral wall is well perfused, the anteroseptal and infroseptal wall isn't, and basically is the case from the base of the heart up until, mid cavity and apex. So we know that this was LED territory and possibly right coronary because the basal inferior septum is also affected. Ischemic, we have been able to induce a perfusion defect, and the only way we could have done that is physiologically at the myocardial bed, we've induced some degree of ischemia. The question now is, are these territories viable? Because we should only be revascularizing viable territory. Otherwise, if you revascularize scar, nothing will change because it doesn't have any blood supply anyway, so you can't recover it. It's now all collagen. So there's no point putting a patient into the cath lab, putting stents through them, wires through them with some, complication profile whilst the wall is not viable. So it's important to know if it's viable. And therefore, we put the patient through a late gadolinium assessment, and we can see that at late gadolinium imaging, which is 10 to 20 minutes after the infusion of gadolinium. So it's basically gone from this to recovery of, myocardial knolling. It's washed out entirely from the myocardium, and we can't see gadolinium hanging out anywhere in the myocardium. It's all black and a perfect circle. So these territories are viable and therefore should be amenable and recoverable with revascularization. That leads us straight into sort of late gadolinium imaging, which I think I have basically just spoken about. Now, further tissue characterization is another domain where cardiac MRI, is king and really does not have any competitor. And that's the ability to assess. Okay, I was frozen for a moment. That's the ability to assess the myocardium in as great detail as can only be comparable to sort of histology. Is it edematous? Is there reason to suspect that there is sort of interstitial fibrosis? And that's what T1 and T2 mapping. I'll just have a quick look at the chart to be sure that. Fine, okay. Just to catch up with the charts, right? So T1 and T2 mapping is really to then assess the myocardium in greater detail to see whether T1 mapping basically gives us information about the extracellular space. Is there expanded extracellular space? I think at session 1, we sort of mentioned about how we have longitudinal and transverse magnetization, and T1 weighted images or T1 mapping is really assessing for how quickly that region regains its 67% of its longitudinal magnetization after a dephasing pulse has been applied. Now, it gives us good information about the nature of that myocardium. Does it have interstitial fibrosis? Could it have elements infiltrating it? We can also actually assess extracellular volume by doing a T1 weighted or T1 mapping pre and post contrast, and then comparing the difference aided by software, and we can tell if ECV is expanded. T2 mapping generally gives us an idea about the presence of water, edema, and therefore is really reliable in acute myocarditis or myocardial inflammation of any sort. Often it's most powerful in acute myocarditis. But it also gives us, it also can be deployed in patients with coronary artery disease, especially when we are still phenotyped and trying to decide what the etiology is. Right. So this is a quick example. I'll just start from the image on my left, the multicolored one. So essentially, this is a patient who had acute myocardial infarction, and they've undergone cardiac MRI. This is sort of the sort of information we can derive from tissue characterization, because T1 mapping, like we said, tests for expanded ECV, extracellular space. And if we keep an eye on the color coding, normal T1 is often about 950, 900 to 1050, 1100, depending on your scanner. So you need to know what it is for your scanner, but it's usually between 950 and 1050 milliseconds in a 1.5 Tesla scanner. And therefore, that's probably in the green area. But we can see that most of this is quite yellow, and therefore the overall T1 for this myocardium is certainly elevated. So we know that there's expanded extracellular volume. It could be edematous, it could be fibrosis. We don't know any further. Now, when we put the same patient through late gadolinium enhancement, we can see that there is late gadolinium enhancement of the basal inferior septum and inferior RV wall, quite in keeping with probably right coronary artery infarct and scarring. But also there is not enhancement here where the yellow arrow is. It's just a blob of black. Now, if we look at the T1 map image, we can also see that the T1 time there was a bit reduced. So we're wondering, what is this? This patient has had a big infarct. They could have a thrombus. They could have other complications of acute infarction, such as microvascular obstruction, and therefore we then put them through ECV mapping, and we can see that the ECV is raised in the infarct zone, but here it isn't in a punctate manner. And that's really because all of here is microvascular obstruction, where you have acute obstruction of all vessels here. And basically, you have a puddle of very exceedingly infarcted tissue. And that's been proven in studies to also have an increased risk of MACE and adverse outcomes. Let's see. Where did this adds? So as again, the image at the top, sort of 12 o'clock position, shows cine images acquired from a patient. We can see that the septum is quite thinned. When we do black blood imaging, it's a bit enhanced, and that generally, gives us an idea about this is likely fatty replacement. But we can see that it's white, and then the surrounding fat is also white. So we don't know if it's just fatty replacement, but the only way we will know categorically if we apply fat suppression sequences. And then we can see that we've suppressed it. So it must be fibrofatty replacement of an old infected tissue. I'll just skip this because we've spoken about that. Now, transmurality of myocardial infarction has been relied upon to guide revascularization. If we have microinfarctions, it could be embolic process shower during angiography, just like here. This is not really compatible with non-coronary anatomy in terms of a single vessel should supply more than here, and therefore this is probably an embolus that traveled down by whatever process. Now, when we look at the image on the top right-hand corner, we can see that we have infarcted tissue, but look, if we use the septum as a reference for the thickness of this tissue, we can see that it's less than 50% of it that is enhanced, and the rest of it is still black and myocardium. And this is subendocardial enhancement is less than 50%. This is thought to be still viable as per outcome data in this field, and therefore we should consider revascularizing the right coronary artery of this patient. But when we look at the bottom left-hand image, we have more than 50%, maybe 50 to 75% transmurality. Outcome data suggests that it's less than 10%. In some studies, it's like 2 to 5% that are viable, and therefore we really should focus on guideline-directed medical therapy for this patient. And this is a convincing transmural scar. It's all scar. We should quantify their scar burden with a view to prognosticating. But yeah. So, if we were performing stress cardiac MRI for a patient with coronary artery disease, this flowchart just basically tells us how we are to proceed, which is, perform a stress perfusion first. So inject a vasodilator, give your contrast, do your perfusion images, and then whilst you're waiting, just acquire your cine images for short axis volumes, and then inject contrast again for your rest imaging, and then you do your late gadolinium enhancement at the end. You basically want to do LGE maximum about 20 minutes from the time you started infusing gadolinium. And sometimes you may need to give a bit more gadolinium here if you've not achieved. There's a target dose of about 0.1 to 0.2 millimole per kilogram that we should infuse into the patients to be able to get reliable images at the late gadolinium enhancement stage. So sometimes we give additional gadolinium here just to make up that dose and then image. So a few other things to say is, we want to stress this image. The patients, we want them to respond to stress. As stress agents are either adrenergics or rely on adenosine receptors. So we have to make sure they're not taking any agents. They haven't taken any agents that interfere with any of these receptors, depending on which one we choose prior to the stress test. So like I said, vasodilatory stress is achieved by adenosine, and beta-adrenergic stress is largely achieved by dobutamine, and we basically have these doses to guide us. There are contraindications to using either agent. As we know, adenosine is an agent we rely upon a lot in the emergency room in diagnosing or truncating supraventricular tachycardias because they block the AV node transiently, but they do. And regadenosine and francadenosine should do that. Therefore, if patients have existing high-grade AV block, you don't really want to test them by blocking it further because they could go into complete heart block, and it may not be safe. They may not be compensated for it, and you could have an emergency that you could have avoided. Also, we know that it causes an element of bronchoconstriction, so we shouldn't administer it to patients with active asthma or known poorly controlled asthma. Beta-adrenergics, just basically inotropic agents, and these contraindications apply. I think it's fair to highlight LVOT obstruction. If a patient has hypertrophic obstructive cardiomyopathy, they should not undergo stress cardiac MRI, as well as patients with severe aortic stenosis. We set off a bit late, so we will overrun 1 o'clock a bit. So these are sort of, things that may occur because adenosine lasts and regadenosine lasts in the system for very short. This is quite transient, bronchospasm, flushing. Some people may have transient heart block during administration, but it goes away very quickly. And the possible complications or side effects from dobutamine are highlighted on the right side. So I'm glad we got here. So essentially, I thought to wrap up with a real life case. This was a patient I recently was involved in their care. And the history is given on the left side. He's a 60-year-old man with traditional risk factors for coronary artery disease. He had been seen in a cardiology clinic complaining of exertional dyspnea. His echocardiogram from like 12 months prior demonstrated just low normal EF, 50 to 55%. So it's not very clear why he's dyspneic on exertion. So he essentially, because his pre-test probability, if we refer to those algorithms from the guidance documents, his pre-test probability is certainly not low. It's intermediate to high because of his risk factors. He was offered CT coronary angiography in the first instance. So he had that. And as this image, so this is an axial slice from his CTCA. As it scrolls down, I will sort of be pointing out so we can see the left coronary system come to view. That's the left main, that was the LAD. And we can see lots of calcification and also areas of hyperattenuation, which could be non-calcified plaque. Left circumflex looks the same, and the right coronary will soon come to view here. And we can see they're all sizable vessels, lots of plaque, lots of low attenuation foci. So it looks like, severe coronary atherosclerosis at least. Now, the problem is that at the end of this scan, this gentleman was sweating, he was hypotensive, he was a bit muddled, and his blood pressure had dropped about 60 millimeters of mercury. And obviously, for CT coronary angiography, patients receive nitrates. However, when we saw him, we thought that his degree of decompensation and upheaval was not compatible with just getting 2 tablets of GTN under your tongue. And this is a bit more. And the images had not even been reconstructed. So we didn't have this to work with, but we kept him observed. And then of course we saw this and admitted him. Now I'm just going to show the MPRs for these, of the same patient. So we can see the right coronary, it's the dominant vessel, and we can't guarantee, apologies, this image keeps skipping. Right, okay, I should play better. We can't guarantee that this part of the lumen is actually patent because there's lots of low attenuation, but that could all be plaque. And there's also a bit of motion there, but it just looks grotty and, with high-risk stenosis. So that's the right coronary. Now we look at the LAD. Again, this was also photon counting CT. So just throwing it out there, photon counting CT is nearly equivalent to invasive angiography in accurate, delineation of stenosis severity. But obviously it gives us a very elegant demonstration of plaque, calcified versus non-calcified. So we can see that the proximal LAD there is a lot of plaque here, and that's the first diagonal, looks occluded. And the second flex vessel is, again, a sizable vessel that basically has a lot of non-calcified, predominantly plaque. So this gentleman has at least severe triple vessel disease, possibly chronic total occlusions of the right coronary, first diagonal, second flex, and this is from CT angiography. Now, like I said earlier, he had previously had an echocardiogram and a year before, and it showed sort of normal, low normal EF. Now, I just put this to show, this could have been his echocardiogram. This is a cine from his cardiac MRI, quite all right. We can see that his left ventricle is enlarged. There's septal desynchrony. He has bundle branch block. There is visually what looks like significant mitral regurgitation. It's going all the way to the roof of the left atrium. There's a bit of tricuspid regurgitation, probably not significant in terms of volume and fraction, but it's a lot. There's some tricuspid regurgitation. We can also see that there is a pleural effusion at the bottom of the right lung, as well as a thin rim of circumferential pericardial effusion. So that's that. Now, his this is RV inflow outflow plane of the cardiac MRI, shows us that his right ventricle is dilated with very reduced ejection fraction. We can't really see any contractility going on here. So we have that information, and that's helpful. Now, cardiac MRI is also able to quantify how much regurgitation they actually have. So we were able to say that he actually has moderate mitral regurgitation with about 34% regurgitant fraction, mild tricuspid regurgitation, about 19% regurgitant fraction. We were also able to say that the comment on the etiology of his valve disease, which is functional mitral regurgitation. And then we go over to obtain late gadolinium images, and that's sort of from the base of the heart to the apex. And we can see that, as this is now real world data where the images are not optimal, and you don't really have myocardium nice and black because the timing is a bit off in when these images were acquired. But we can see that there is enhancement in the lateral wall, late gadolinium enhancement of the lateral and inferior wall, really from the base of the heart, and it keeps going all the way. We're now in the mid cavity here, and there's still quite transmural enhancement here. So this was reported as transmural enhancement of the inferior wall, subendocardial enhancement of the, transmural enhancement of the lateral wall from the base of the heart to the distal cavity. And there was also a bit of subendocardial enhancement of the inferior wall. Now so these are long axis late gadolinium images, and we can see that there is significant enhancement of the lateral wall as well as the inferior lateral wall here. So, and this is all transmural. It's more than 50% that is enhanced. When we compare it to the thickness of the septum, we can see that we barely have any myocardium at all, just that stripe. So we can confidently report that there is transmural infarction of the inferior lateral wall. Now, how that translates to the care of this patient whose arteries are like this, because the big question that the interventionist would ask us is, which vessel do I revascularize? How do I know? Everything looked impaired on the cine imaging. If I just go back to the cine imaging here, it's just the 4-chamber, I agree, but everywhere, nowhere was doing better than the others. We can see that lateral wall is thin, so we had a high index of suspicion that it will be a transmural infarct, but this is not great either. How are we sure? So we can then reliably inform our interventional colleagues that the right coronary artery is a CTO as per our angiography, and we can see it on invasive angiography. It is a CTO with lots of collaterals from the left. You can see that the right coronary basically stops here. let's go over the LAD. Now, let me just stop it. Hmm. Yeah, so left main LAD, and we can see the substantial stenosis here in sort of your proximal to mid LAD. A diagonal comes off here that also completely blocks off. It appears it doesn't continue. And the rest of the LAD is a sizable vessel. So we have a substantial stenosis. But then our cardiac MRI has told us that this anterior wall is fully viable. And we also know that the anterior wall contributes the greatest proportion to contractility as well as prognosticates outcomes when healthy. And it's reasonable to revascularize this vessel. It's also entirely unreasonable to attempt to revascularize the circumflex, because we know that the wall it supplies is completely dead. Transmural infarction, there is really no point. So this gentleman is verging on cardiogenic shock. So he has a mechanical circulatory support. He has an impeller assisted revascularization. We can see the wire going into the LAD, and we can see what it looks like before on the right. And I'll just stop it where we can see what it looks like after revascularization. So, we've restored that luminal caliber. We have revascularized his anterior wall, and we would expect that this man will do much better. So you see, we would not have been able to offer this man the best care that he needed at this point if our investigation ended with a transthoracic cardiogram and his CT coronary angiogram. And I've just summarized all that he had sort of in the sequence here. And we can see that it was with the cardiac MRI that we could offer him guided revascularization of the most relevant aspect of his coronary anatomy and supply. We also have information that he has a lot of scar, and his ejection fraction is quite low, and those are prognostic markers. If his ejection fraction remains less than 35% after revascularization, then his sudden cardiac death risk has not really been reduced by revascularization, and therefore we should offer him a defibrillator. And that's really what he's waiting for at this point. What time is it? Right. So back to this infographic, and we can see that, with cardiac MRI, we screen for both ischemia, dysfunction, scar burden to guide prognosis and treatment. We also screen for other things as per previous slides. I think my key message is that it actually, CMRI offers us meticulous assessment of patients with coronary artery disease through their life course. It's a dynamic disease process. Things change over time, and we just need a tool that gives us the most relevant, prognostically relevant information to take the next best decision for the patient. It reduces unnecessary testing and invasive procedures in this long run, and cost effectiveness studies have demonstrated this without a doubt. It's impeccable, signal to noise ratio, image contrast, excellent spatial and temporal resolution, and the absence of ionizing radiation actually make it a desirable tool in the assessment of these patients. Thank you, everybody. We will be grateful to receive evaluation forms.
That was fantastic. Thank you very much, Dr. Ofong, for covering a topic that could take several hours in just under 1 hour. That was a fantastic talk and with a lot of content. And I'm sure quite a lot of people here, just like me, would want to go back and rewatch this because there were several aspects of it that I'd like to watch again, just to consolidate knowledge. So the good thing about these sessions is that they are recorded, and at the end of it, you're going to get a link to a YouTube channel where you can basically rewatch some of these studies and consolidate knowledge. So we have eaten into your weekend time. So I'm going to crave Dr. Fong's indulgence to spend about 20, 30 minutes answering a few questions. So it's going to be like real quick answers. And where we stop within the next 20 minutes, we would call it a day. And then any other questions, we've already got copies of the questions, we will have the answers sent to you via email. So we'll start with the first question from Aderemi. He's asking, how reliable is calcium score in risk stratification, as a non-calcified plaque can also cause obstructive CAD?
Agree. Yes. I agree completely, Aderemi. The data from which calcium score was derived, the cohort, there were studies done in the global north, which brings us all to another passion that we all at the consortium that you see that have put this together are quite passionate about, which is conducting trials and deriving data from our African cohort. A calcium score of 0 does not give you the same power in an African or a South Asian individual as in a Caucasian individual, simply because, data is garbage. What you put in is what you get out. If you get data from X population, you cannot necessarily apply it to Y population. And this is really because of the presence of non-calcified plaque. And that's why the investigation algorithm is still a lot on symptoms and sort of your pretest probability before you decide. So if you have someone who is African or South Asian, who's diabetic, who has a family history, who is dyslipidemic, and probably youngish, and they come with a story that is quite suggestive of angina. A calcium score is probably not your best test because their pretest probability is already not low risk because of their other risk factors. And maybe a CT coronary angiogram will give you more data at that point because we're looking at the lumen itself. We would also give a statement about, their CADRAS class from a plaque and a stenosis perspective. But yeah, it's all about, I agree with you that it's not as foolproof in our population.
Yeah. Okay, good. Next question from Sorochi is asking, is the 4-chamber imaging technique similar to that of echo?
In principle, that's what we're trying to. But as you can see, if we go back to that slide where we had sort of compared, even 3D echo performed really poorly in correlating with itself. And we know the problem with echo is a good echo is excellent in a good hand, but a good hand could also be affected by if the patient is breathless, if the patient has body weight has changed over time. So in principle, it's similar to a 4-chamber view from echocardiography, but it's not really apples to apples because the way we align it is very different. But the principle is same.
Yes. Thank you very much for that. Just to add a little tip as well, being that echo is an ultrasound technique which is operator dependent, the way the exact correlation would depend on you doing a good quality echo by a good quality echo cardiographer, rather than for it to compare like for like, it has to also be a good quality echo that you're comparing.
Exactly.
Yeah. So next question again from Sorochi is asking, in places where stress MRI or cardiac MRI is not available, can the angiogram images we obtain in the cath lab to some extent help in replacing those functions?
So I think, if we don't have stress MRI, then we can't comment on inducible ischemia or inducible perfusion defect. Now, what we get from the angiogram is not really inducible perfusion defect. So what we do in the cath lab is absolute anatomical assessment, and what we do in the cardiac MRI magnet is functional assessment. Now, in the cath lab, with the advent of intracoronary imaging and pressure wire assessment, you can add on a flavor of functional assessment when you put a pressure wire down. But remember, the data you get, which is fractional flow reserve or IFR, is actually a surrogate for flow. And you're trying to say that if flow is this reduced, then the probability of ischemia is this. So you see, it's now a proxy of a proxy. Whereas the stress MRI is direct induction of vasodilation into the vessels and seeing if perfusion is different. So it's a direct assessment of ischemia. I guess you can only compare it to sort of stress PET myocardial perfusion imaging or SPECT perfusion imaging or stress echo. But what we're getting in the cath lab is a flow assessment that we're now applying as a proxy to ischemia.
Thank you very much. Yes, that's also the same thing with people who do CT FFR and CT coronary angiogram as well. That's still, again, not quite the same thing as what you would get with the MRI as has been described. So the third, another question from Felisani, he's asking for patients whose GFR is way below the acceptable level and they have ischemic myocardial disease, how do we go about doing CMR, keeping in mind that gadolinium injection may not be advised? What sequences will be put in practice for such cases? That's a fantastic question.
That's an excellent question. Excellent, to the topic, but also to our organization, so to speak. So unfortunately, when we have a renal function that precludes administration of gadolinium-based contrast agents, and I sort of say that in that way because there are 3 generations, I believe now, of GBCAs. And the better their relaxivity, the less effects they have on the renal function. And hemodialysis patients can have gadolinium because it's dialysable. The problem is really patients who are not yet at dialysis but have eGFR less than 30 or indeed less than 15. You really, in good conscience, can't give them gadolinium. Now, there is unfortunately no yet a validated strategy to perform stress CMR without gadolinium, but there's lots of research on the topic because it's not just you asking the question. And actually, I'm certain that Professor Friedrich, when he takes his sessions later on in our webinar, will educate us all on a non-gadolinium-based perfusion protocol he's developing, which is oxygen sensitivity, i.e. by inducing sort of hyperventilation. And there's a few centers in the world that are actively researching this. But, at present, what I'd recommend for that patient is that you could just do a viability MRI. You could just do a viability MRI. So basically get all your non-contrast based sequences, get T1, T2, T1 and T1 at least can give us a good idea of interstitial fibrosis. In fairness, if patients have advanced, like well-established scar, we can actually see a hint of it on cine imaging. And we may just have to rely on, conventional tools like sort of a treadmill or a stress echo.
Okay, thank you very much for that. So we've got Adiwale asking that you go through the stress protocol again, but I think he said he missed that part, but that will be in the video. So I think it may be best to wait till you watch that video. You'll get a bit more detail rather than try to rush it through. And he's asking for T1 mapping. You mentioned that we should acquire in mid-systole. How do you achieve that?
So remember that all of our cardiovascular imaging is ECG gated. So we know systole and we know diastole and we know where mid-systole is, So essentially it's about once your ECG trace is right, you don't necessarily, the ECG requirements are already built into the sequences and the scanner will find the right place and take images there. But that's why you need your ECG coils and all of that. And you need to have a clean ECG trace so that your scanner is reading the ECG right, and then it will get it done. So we're entirely reliant on the ECG for all of this.
Again, a technical question from Vivian asking, what is the best time to start perfusion once the heart is stressed to avoid doing it too early or too late? And what symptoms should they look out for when the patient is stressed? And if none of those symptoms are seen, would that suggest that the patient is not stressed? I'm paraphrasing.
Agree.
Yeah. Okay.
Lovely question. And yeah, entirely technical. So what's the best timing? I think what we have generally done at my centers is to like that workflow I showed, basically stress them. Remember, stress sequences are quite free breathing anyway, so there's no breath hold. And in that time, so basically you admit you achieve your you get your localizers, you get and then you give your stress agent. Once you give your stress agent and then they get symptoms, and I'll talk on the symptoms later. And then you start administering your contrast, and that's when your perfusion starts. So you start acquiring your perfusion images, usually about 1 minute after you start. Some do 2 minutes, but after you start your stress agent, you start your gadolinium and start acquiring the image. Free breathing. Because it's now free breathing and you're getting to the end of your stress, your patient has started resting or coming back after all of that upheaval. Then you can achieve your cines, acquire your cines, and then that's the end of it. So basically, the question is, some people do, depending on the patient and how compliant they are, some centers do the cines before the stress, others do the stress, cines, rest, and then late guard in that order. And I think that's really the flow chart I showed was from the CMR guideline, and that's really what they recommend. There's every institution usually has like a form, tick box of, because you need to monitor blood pressure before you start the MRI test, then blood pressure before you start, and heart rate before you start administering your stress agent. Generally, we think with stressed people when we have increased their heart rate by 10% and blood pressure reduced, because remember, it's vasodilatory, so the blood pressure may drop a bit. But the thing is, the blood pressure is not as reliable because they're also frantic. So they are being frantic may just push it up, and your blood pressure just keeps going high and high. So if they have no symptoms, it does not mean they've not been stressed. But there's this thing of splenic switch off, which we rely on a lot in PET imaging, and which actually has been proven to be in MRI imaging. Basically, because we know that there's one aorta, there's one cardiac output. And we know that physiology of coronary steal syndrome, that you can divert flow to one place or the other, depending on what the body needs most. Now, it's been demonstrated that with vasodilation, there is a preferential vasodilation that occurs in adenosine-based stress agents. There is a preferential diversion of blood flow to the coronaries rather than the splanchnics. So you would see the coronaries get perfused, like in PET, where it's a radio tracer that is bright. You see the the myocardial bed get bright and the spleen switch off. And we actually see splenic switch off as well in cardiac MRI, where, like the images I showed where the myocardium is white and perfused, you can see the spleen really dark. And you can say the splenic switch off has occurred. But if you have no switch off, no heart rate change, no symptoms, then we would include that in the report, that we're not convinced that this happened. Yeah, that the patient was stressed.
Okay, good. Thank you very much for that. In the interest of time, I'm probably going to take 2 more questions, and the rest of it, I promise you're going to get an email with the answer to your question, and that will be shared with everybody so that they can also benefit from the knowledge. Got a question from Jennifer asking about for gadolinium enhancement, what is the ideal interval for image acquisition following GAD? I think you just talked through that in this last question, hopefully. I think that's the last question, the last answer you gave sort of covered that. There is an anonymous attendee who's asking, how do you determine what patients with less than 50% lead gadolinium enhancement have? That's in terms of management, CABG versus stents. So how do you determine which, if they've had less than 50% lead gadolinium enhancement on MR?
That's a separate webinar with a different set of trials. And it really depends. We know that, the choice of revascularization depends on patient factors and coronary anatomy factors, age, diabetes or not. Diabetes is a strong influence on the choice for coronary artery bypass grafting because of diffuse disease and the risk of progressive disease, and therefore they tend to scupper their stents in a short time, like in-stent restenosis, all of that. And also what you know about the patient, how have they behaved with other stents. So it's, and those are like patient factors, and then anatomy factors, syntax score, and all of that. So yeah. It's not the MRI that decides. It's the interventionist and that body of research and trials that decide, yes.
Okay, we'll take the last question, and then the rest we will email the answers back. Got Aderemi asking, what is the significance of right ventricle parameters such as volume and ejection fraction in patient management?
Excellent. Now that's excellent from my point of view, especially from my heart failure heart. The right ventricle was in previous cardiology discourses and referred to as a forgotten ventricle and all that because we didn't really know much about it. We know it doesn't pump to the body, etc. When it gets infected, patients don't tend to drop off and die. But I think a lot of information in the last couple, or maybe last decade and more, has proven that, the right ventricle and its size function is a good indicator and a good prognosticator. For example, in patients who have left ventricular disease, like coronary artery disease, the progression to right ventricular dysfunction is a red flag. It is a marker of imminent, it's a red flag. Essentially, it's a bad prognosticator because it means that they've now progressed to pulmonary hypertension. Because remember, the conduit, if the left ventricle fails to such an extent for it to affect the right, there has to be high pressures in the pulmonary bed. And that is associated with adverse outcomes. That means that certain things they can have in terms of interventions, they will not be offered it because patients with pulmonary hypertension, which is elevated pulmonary arterial pressure, do poorly on bypass and cardiac and non-cardiac surgery. So that's that for right ventricular function as a prognosticator. It's really about, right ventricular dysfunction is almost a corollary for pulmonary arterial hypertension, and the advent of pulmonary PAH or pulmonary hypertension in patients who have left heart disease is a very bad prognosticator factor. The other utility of the right ventricular assessment is in volumes. We can't we really need the right and the left volumes to comment on things like shunt fraction in patients with congenital heart disease, a VSD and ASD, or any shunt anywhere, because cardiac output on the left should be equal to cardiac output on the right. But we need to have those two numbers to then say that the shunt fraction is this, that QPQS is this. Now, QPQS is the ratio of pulmonary flow to systemic flow, and that is an index that is incredibly relevant in the adult congenital heart disease or pediatric cardiology world, because that's really what tells you this is actually a hemodynamically significant shunt. The ASD or VSD is not significant based on size, it's significant based on hemodynamics, and that's what actually gives you that number. So, RV function is incredibly relevant, RV volumes, for this reason as well.
That's excellent. Thank you so much, Dr. Ofong, for a wonderful talk. We could go on and on and on, and I'm sure people have questions, but don't worry. I'm sure some of these questions may also be answered at later sessions. So just to wrap up today, because I'm aware that we've eaten into your evening quite significantly, I'm just going to show just a reminder of what's coming. So this is just to show you what's coming next. So there will be another talk, and it will be given by Dr. Ofong on the 2nd of May, and it will be a talk on CMR in non-ischemic cardiomyopathy, and this is a part 1 talk, which will be looking at phenotyping. There will be a part 2 talk on the 9th of May, looking at the same topic, but looking at infiltrative and inflammatory pathology. So these will be just as interesting as the other ones, and you're getting the full spectrum of what CMR has to offer, and hopefully your patients will benefit as well from this body of knowledge. So thank you very much for joining us. If you haven't completed the survey, please do. We will definitely, for people who are asking, we will send you the links of the first 2 lectures by the end of the week. I've been promised by our admins, and this one will follow, because all of them we need to edit and make sure that it's actually audible for you before we send it out to you. So please bear with us. We haven't forgotten. You will definitely receive them. So thank you again for joining us, and we look forward to seeing you again same time next week. Enjoy the rest of your weekend.
Okay, thank you. I'm going to be logging off now. Bye.